very much, Dave, and thanks ever so much for giving me the opportunity to talk with you all this afternoon. So I'm sitting in Cambridge, even though I work at UCL, and just as a bit of a forewarning that the internet, I don't know what the internet's like in Oxford or where you all are, the internet in Cambridge is absolute rubbish. So if I drop off, I will try my best to reappear as quickly as possible, but just a little bit of a forewarning that sometimes I do disappear from your screens. But as Dave said, what I'm going to talk about is the work that we do in Global Health 50/50, which focuses on gender equality across the global health system generally. But I'm going to use COVID-19 and the work that we're doing in COVID-19 as an opportunity to really think about what COVID-19 has shown us about some of the lack of resilience within the global health system more generally, and what this means moving forward. So hopefully you can all see my slides and I'm on full screen. Is that correct? Great. Okay, so I'm just going to start in the first couple of slides, just sort of going through a little bit about what Global Health 50/50 is. Not for any other reason than just to sort of talk to you about a bit about how we see the use of evidence and data, and what it is that we're trying to do with this different way of communicating about issues of evidence and data. So I've been working in global health for a very long time, about 30 years. And so, you know, like everybody at their sort of the age and stage who's spent their, well, I haven't spent my entire life in academia by any stretch of the imagination, but I've spent a significant proportion of my life in academia, and like everybody else in our profession, have got the metrics of, you know, money in, papers out. And so this is just a slide that shows you the kinds of work that I do as an academic, which is very much work that is you know, predicated around that academic model of you collect high quality rigorous evidence, you put it out there into high quality rigorous journals, and hopefully this will have an impact on policy processes. And for all of you who are studying or working or researching in the field of evidence to policy, you'll know that's an incredibly naive view of the evidence to policy process. And I guess it became a kind of view of the evidence to policy process that as the years went by was not only increasingly naive for us, but was also increasingly non-impactful. And this was really shown or highlighted for me and my co-founder of Global Health 50/50, Kent Buse. And if you look down in the sort of left-hand corner of this slide, you'll see a paper that we put out more than 7 years ago, which was sort of overview paper looking at the evidence around gender equality, health equity, and the global health system. And you know, normally if you put a paper out in the Lancet on a fairly big topic like this, you get a lot of interactive feedback from in various fora. And one of the things that happened with this paper was that it was remarkable for a complete absence of any communication or feedback whatsoever. So here, you know, we put out what was essentially, we thought, a fairly important message about gender and global health, and were met with total silence. And so we thought, well, actually, you know, we still believe in this message, and I'll come to the message in a minute, but we need to find a different format for the messenger. We need, you know, we really need to think again about what it is that we're trying to do and who we're trying to reach. And so a couple of years later, we decided that what we would do would be to establish an independent initiative, and we've called it Global Health 50/50, that really tries to take the core components of that Lancet piece, which was the culmination of many years of thinking and doing research and collecting data on gender and global health, but really try and communicate it in a very different way. And for the purposes of full transparency, I should point out that Kent Buse, who is a political economist of global health, and at the time that we set all of this up and did those Lancet, the Lancet paper, etc., was the chief of political strategy at UNAIDS. More importantly, for the purposes of transparency, is also my husband. So this is an entirely gender equal partnership to try to promote notions of gender equality within the global health system. And I suspect we could talk about this afterwards, perhaps, but I think that one of the things that the UN system does quite well, surprisingly to some of you perhaps, is it actually has really good comms departments. It has a really particular way of communicating, and we drew on some of that lesson learning in the way that we then began to communicate our core message about, or core messages about, gender and global health. And what we were trying to do within this initiative is really look at two interrelated but separate streams of the relationship between gender equality and global health. And one is the part that I will concentrate on in terms of COVID, is the actual relationship between gender as a social construct and what that means for health outcomes. And the other stream is looking at gender as a social construct and what that means for people's career opportunities within the global health system. And so that I think those two streams are in fact related, but they're two streams that we now measure different variables around those two streams across 200 organizations in the global health system on an annual basis, and produce an annual report with an interactive index, which is what you see on the bottom left-hand side of the slide. We produce guides about how to achieve gender equality, what gender responsive health programs might look like, etc., etc. And we do a lot of public engagement. So down at the right-hand side of the screen, for example, you see our photo competition. Here's our photo competition, just been launched again for 2022, but sorry, for 2021. So if any photographers are in the audience, please do go to our website and submit your photographs for our annual competition. But it's just, I'm just highlighting all of this as a way of saying that we're really interested in different ways of thinking about and communicating and using data. But at our core, what we are really about is data, not just as this idea that data is somehow a package of evidence on which policy level decisions can be made. The data is a means by which we, all of us, can hold systems to account. And that's where we're going to segue into a little bit later as far as COVID is concerned. So this slide just reminds you again of the two domains that we look at in Global Health 50/50. So, I think I'm going to hazard a guess that at this stage in the academic year, we're probably in the first or potentially the second week of term. I'm sure there's lots of students on this this call, this Zoom call, and I'm sure a lot of you are young, and you will have your own vision of what gender means when you hear the word gender. And it will mean different things to all of you. I think that's one of the things that's become very clear in the world of gender over the past, certainly over the past couple of years, is that it's a very contested terminology. It's politically contested, it's ideologically contested, and it's contested even within the sort of the political sphere of people that you might expect to be on the same side. But one of the things that has become clear to us, and was one of the reasons why we wrote that original Lancet piece, is it becomes very clear that within the realm of global health, that when the global health system is talking about gender, what it's really talking about is women and girls. And what we've always tried to put across is that gender applies and has an impact on everybody's health. And that again is going to segue into some of the work that we're doing on COVID, to show that we are not just talking about 50 or 51% of the population. We're talking about everybody when we talk about gender and its relationship to health. Even though, you know, at the level of high politics, it's very clear that some political leaders, when they hear the word gender, what they hear, oddly, is the term homosexuality, or they hear the word transgender. So everybody kind of picks and chooses a little bit of what they're going to fight over about gender, but we're talking about all of that and what it means for health and careers. So given that there are all of these contested notions and ideas and ideologies about gender, we have taken a normative definition from the World Health Organization, if you like, as our kind of cohesive notion of what gender means to the global health system. So gender is about socially constructed behaviors and attitudes and aspirations and attributes and opportunities that, as I say, apply across the board. So this is the WHO definition. I could give you another 30-minute presentation on the contestation that went on behind this fact sheet, but that's another talk entirely. But this is essentially what the normative agency within global health, i.e. WHO, defines as gender. And so we use this as the basis for the work that we then do to understand the relationship between gender and health outcomes. And over the years, we've developed a conceptual framework that really says that gender is embodied, enabled, and enacted in its relationship to health outcomes. So gender very rarely operates as a single notion, a single variable to influence health outcomes. It interacts, it intersects with other measures and drivers and determinants of inequality. Social, economic, commercial, political, legal determinants that if you're a gender theorist and you're into notions of intersectionality, gender is an intersectional variable that essentially means that the gender experience of an educated white urban woman are really quite different to the gender experiences of somebody who's living in a rural area, is not educated, is poor, etc., etc. And we need to recognize those disaggregations within the notion of gender. Gender impacts directly on health behaviors, whether those are protective health behaviors, i.e. you go and seek screening services, or you go and seek medical care if you've got a problem. But they also, and I will emphasize this in the remainder of the talk, they also influence, gender also influences harmful health behaviors. And I'll come back to that. And gender influences the construct and the structure and the delivery of health services. It influences who accesses health services, it influences who health services are trying to reach, and it influences the careers of the people working within those services. And all of that kind of Venn diagram of how gender permeates all of these intersecting variables means that it has a direct influence on equity in health outcomes. And I think, we see this. Here's WHO data from 2019, and it's a very simple measure. It's okay, you're born in 2019, how long can you expect to live? And it's really clear, even if you're not an epidemiologist, I'm sure you can look at this graph and see that if the solid circles are women and the open circles are men, and the different colors are because they're talking about the income status of the country, that no matter what the income status of your country, you are likely to live longer as a woman than as a man. And the global difference is around 5 years, but it ranges from about 2 years to, it ranges from about 1 year to about 12 years, depending on where you are in the world. And so what we're saying is that a large part of that difference is driven by gender. And WHO, actually, let me just go back to that slide. WHO has been presenting these kinds of data on sex-disaggregated differences in health outcomes for precisely 1 year. So WHO presents data on the health status of the world every year, puts out an annual report on the World Health Statistics. So you can find out, how many people in Latin America are suffering from diabetes. But if you had wanted to know how many people in Latin America who were women were suffering from diabetes, you had to wait until 2019 before WHO could tell you that. So it's only within the past year that WHO has been sex disaggregating its data. And once it started to sex disaggregate the data for their 2019 World Health Statistics report, they found that sex difference in life expectancy. And so they then started to look at, well, what is it that mainly contributes to the sex differences in life expectancy? And what you see here, everything on the dark blue, or it might look black on your slide, left-hand side of this bar chart is male excess mortality. Everything on the right-hand side that's in yellow is female excess mortality. So you'll see here the main contributors to male excess mortality. Now, if, like me, you've spent 20 years embedded in this literature, this is not at all surprising. But for WHO, it was surprising enough that they devoted an entire page in their annual report to showing why men don't live as long as women. And these are the main conditions that contribute to that lower life expectancy in men. And it encompasses, for example, issues like interpersonal violence, which is an area that is very surprising to many people working in global health, who think about gender-based violence as something that men do to women. And of course, gender-based violence is something that men do to women. But when you actually look at the evidence, the biggest contributor to lost years of potential life is the gender-based violence that men do to other men. So this does not even include state-level violence of a state deciding to send young men into war. This is the level of violence that men do to each other. So, there are we could unpack this slide again for the next 30 minutes about what it's actually showing us. But essentially what it shows us is it's possible to really try to understand why is it that we see these differences in the health and life expectancy outcomes between men and women. Hold on. So I'm including this slide to say, okay, it took WHO about 30 years before they really recognize that there's this big difference between men and women in health outcomes. But actually, for those of us that have been studying this for a while, I have not been studying this since 1662, although it sometimes feels like it's been that long. But luckily, other people have been studying this for a very long time. And way back in 1662, John Graunt, who is seen as really the great, 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 great grandfather of epidemiology and demography, noted exactly what WHO noted in 2019, which is that men tend not to live as long as women. And back in 1662, he put it down to men dying by reason of their vices. And I'll come back to that because I think that has quite a lot of resonance to the issues that we're talking about today. So it could be argued, if in case there's any natural scientists or biologists or geneticists amongst you, that the reason that we see those differences is all down to sex. It's all down to the biology of sex. It's all down to something around an innate, inherent difference between men and women that means that men simply are not going to live as long as women live, and they're going to die of diseases that will probably kill women eventually, but women are stronger, they're more able to resist it, and therefore they have a longer life expectancy. I would question that as 100% of the answer as to why we see the difference. And so the next few slides are going to explain to you why I don't think that that captures the entire rationale for those life expectancy differences, or the disability adjusted life year differences that we see between men and women at a global or national level. I'm going to explain it to you in the case of COVID-19. So when COVID first sort of came onto our consciousness, which in global health 50-50 was really around the end of January, beginning of February this year, we were right in the midst of collecting up the data for our annual report. And one of the things that we assess each organization by is whether or not it sex disaggregates its data. So you've got these 200 organizations in global health. They do things like they deliver 25 million vaccines a year. Are they delivering those vaccines to girls or boys? Well, you'd be surprised how many organizations actually can't tell you whether they're delivering vaccines to boys or girls, because they don't sex disaggregate their data. We think it's really important to sex disaggregate data. So we measure this as one of our core variables. And it really hasn't changed over the years that we've been measuring it. It's under 40% of organizations that sex disaggregate their data. So when COVID came along, we all looked at it and thought, gosh, I wonder whether countries will tell us whether or not this pandemic is affecting men or women or both, and how it's affecting them. What proportion of people getting COVID or being hospitalized with COVID or dying of COVID are men or women? So we started to look for that data towards the end of February, beginning of March, and we didn't find it. And we didn't find it, and we didn't find it, and we thought, well, perhaps we're looking in the wrong places or whatever. And so we went to the WHO and said, where's your sex disaggregated data? And they said, we don't have a mandate to collect sex disaggregated data from countries. We can recommend it, but we can't mandate it. And so if you go to WHO, all you get is the aggregate numbers, which fits in really with what we're seeing here, is that the global health system, despite all of the evidence I've just shown you about what we think is the importance of knowing that there is a difference between health, in terms of health outcomes by gender, the global health system tends not to report that. This is not, it's not a figure that people are generally concerned about. So we, retrospectively, possibly somewhat foolishly, decided as GH5050 to step into that data gap, and decided that what we would do is start to collect that data ourselves. And we started off at the beginning of March looking at data from about 20 countries, and we're now up to collecting data from 179 countries. And we collect this data on a fortnightly basis, and we look at, it's been a really fascinating exercise in so many ways, not least of which is discovering how in 2020 governments communicate data. So we had expected to be able to go to the ministries of health of those 179 countries and find all of the data that we're interested in looking at. But instead, what we've discovered is that ministries of health in 2020 do what the rest of us do. They put their data out on Twitter, or they put it out on Facebook, or sometimes, if you're really unlucky, they put it out on YouTube, and you have to sit through 2 hours of a Ministry of Health presentation in order to get that one data point that you're really interested in, which is, okay, you've got X number of COVID cases or deaths in your country, how many were in men, how many were in women. And what you'll see from this map is that this shows you how many countries were sex disaggregating their data over the preceding month. So this is actually up till the first week of October. So this is the month up to the first week of October. And you'll see that actually the majority of countries in the world are not reporting sex disaggregated data at all, despite 3 centuries of evidence telling you it's probably important to know something about the distribution of a disease between men and women. Countries just aren't doing it. And if they do it once, many times they then don't do it again for another 5-6 months. So they have, they put the data out there, and it's as if, well, we've done that now, we don't need to think about it again. We collect data along what we call the test to outcome pathway. And you'll see that in only 8 countries can we find data on who goes and gets tested, which we think is a really important figure to understand. If what you're trying to do is control a pandemic, you'd want to know, is it only women going and getting tested? Is it men? Who is it we need to encourage into the testing system? No idea, because only 8 countries actually tell us that. 125 countries at some point have reported data on sex disaggregated information on confirmed cases. You can see the numbers along here. We look at how many tell us about cases in health workers, how many tell us about hospitalizations, are you going to be admitted to ICU, and what's your chances of dying? And you need to know sex disaggregation at each and every one of those points if you're going to understand the testing to outcome pathway. And here's what we see across all of those countries when we put it all together. We see that essentially fitting in with everything we know about male bias in not seeking screening services, men tend not to seek testing as much as women do. And that fits a global pattern for many diseases. When it comes to confirmed cases, you've got a slight male excess, but generally for most about, which is what you would expect with a respiratory virus. There really shouldn't be too much of a difference between men and women in terms of cases. But it turns out men are more likely to get sick, and they're more likely to be hospitalized, and they're much more likely to be admitted to ICU, and they're much more likely to die. And if we disaggregate that by age as well, we see that when you get into the older age groups and you look at rates per 100,000 of the population, male excess deaths are 2, sometimes 3 times higher compared to female excess deaths. So in other words, this is an infection that appears to be relatively equally spread throughout the population, but has an excess mortality on men, just like many of those other diseases that we saw in the life expectancy charts, where they have an excess impact on decreasing men's life expectancy. So the question is why? You know, it's the same questions that you could ask for any of those other diseases. Is it all down to biology? There is some evidence that there are indeed hormonal and immunological differences, and I'm not a biologist or a geneticist or an immunologist, so but I can try my best to answer some of your questions, but I might have to ask you, or you might be better off asking somebody who really knows what they're talking about the sex differences. But there are indeed some sex differences that could explain some of the excess male mortality. But if it was all down to biology, you would expect, one might imagine, to see very similar rates of difference between men and women across populations in most parts of the world, and you don't. You see really big differences in populations dependent upon, for example, the gender equality ratio of the country. So this is looking at the proportion of deaths, the proportion of COVID deaths that are in men, and what's called the gender inequality index of a country, which is a UNDP aggregate measure of gender inequality in the country. And we see a relationship, a statistically significant relationship between a measure of gender inequality and the proportion of COVID deaths in men. The more gender unequal a country is, the more men you have dying, is the simplest way to think about it. So if you're in Canada, which is relatively gender equal, you've probably got a closer relationship between there's a much smaller difference between the death rates in men and women in Canada compared to, let's say, Afghanistan, where you've got high levels of gender inequality and you've got much higher death rates in men. So what if everything was all down to biology, we would not expect to see this kind of relationship present. I'm going to just go back one slide to say that, you know, going back to our conceptual frameworks, we think that gender is playing a role across potentially a number of different areas where there could be an impact on gender norms, gendered systems, the gender regime, as Connell calls it, and men's poorer health outcomes. And I'm gonna illustrate that. Well, actually, let me first of all, no, I'm going to move on. I'm just going to talk about it in relation to the role of health behaviors and comorbidities. So comorbidities are it's the presence of other diseases, frequently the long-term chronic non-communicable diseases that we know are associated with higher rates of death and higher rates of hospitalization, higher rates of death amongst people with COVID, is that they are more likely to have these comorbidities present. We also know that those comorbidities are more likely to be present in men. So here's why we think that this is not all about biology. We think, let's take the case of, let me just go back, let's take the case of heart disease and lung disease. The biggest attributable risk factor for heart disease and lung disease globally is tobacco smoke, okay? I want you to just look at the figures, the WHO figures for who smokes. Who is it at a global level who is likely to be a smoker? So the top bar graph is the adult population aged 25 to 69. The bottom one is young people aged 15 to 24. The parts of the bar chart that are in blue are men, the yellow are women. And the letters on the bottom are the WHO regional offices. So Southeast Asia, Western Pacific, the Middle East, Africa, sorry, I need to move this, Europe and the Americas. And again, you do not have to be a trained epidemiologist to look at that and say smoking is a male behavior. It's very clearly a gendered behavior. And if you now look at remembering why is it that men don't live as long as women? Well, a large part of that, estimates over the course of 130 years, are that 30% of the excess male mortality seen in 15 industrialized countries is directly attributable to men's smoking rates compared to women's smoking rates. So we know that there are these, and these are exactly the conditions that are associated with as the comorbidities that lead to an increased risk of death amongst people with COVID. The smoking related conditions, for example. Smoking is one of those areas that the global health community actually pays remarkably little attention to compared to the burden of disease that is associated with it. So there are some national programs that are pretty good on smoking control, but as a global health system, we have not been paying nearly as much attention to tobacco control as we have been paying, for example, to the targets within the Millennium Development Goals. And again, I can come back and explain that later. But just to say that smoking is not an area that we have paid much attention to. And again, this is data from Global Health 50/50. If you look at what those 200 organizations in the global health system, less than 10% of them work on tobacco control. And when they do work on tobacco control, they focus entirely on tobacco control in women. Or they say it's gender, we're not interested in gender. We're not going to talk about gender. We're not going to mention gender. But if we do mention gender, we're going to focus on women and tobacco smoking, despite the fact that, they saw those blue and yellow bar graphs in the same way that we did, unless they got the colors the wrong way around. But they still then say, well, let's focus on women. In contrast, since the 1950s, there is very clear evidence that the people selling tobacco really understand gender. So the perpetrators, the people who understand market segmentation have been extraordinarily good at understanding, exploiting, manipulating, and making a profit from gender. But as public health practitioners, we just don't really pay attention to it. It's not something that we've paid really enough attention to, unless it relates to, I'm going to say women's health, but what I really mean by that is unless it relates to women and their reproductive capacity. Hence my concern right at the start that definition of gender, as it's understood by the global health system, is about women and their reproduction. It's not about gender as it relates to all these other things that are going to afflict all of us at some point across our life course, that other people have understood and are manipulating us according to our gender to engage with these behaviors. This is just a really quick slide to show you again that it's not just public health, it's, you know, it's the health research complex as a whole, that if we've analyzed the first 1,000 publications that came out during the COVID pandemic, and we see almost, you know, a remarkably small amount of attention being paid to sex and gender in published studies. So despite the fact that you've got double the risk of death if you're a man in many countries, most of the studies we looked at did not even bother to sex disaggregate whether they were telling you about people with COVID who are men or people with COVID who are women. So, you know, this gender blindness is a comprehensive gender blindness in both public health and medical research more generally. So I'm going to end up just the last couple of slides to really try to think about, well, why do we have these levels of gender blindness? And I think there's a whole, you know, actually, if you really look deeply into it, there's kind of 2,000-year history that you could go refer back to the time of Aristotle to really start to think about, you know, where does that notion of gender blindness come from, which often translates into focusing on one sex compared to the other. But we think that a large part of it is driven by the leadership of global health. This is a leadership that thinks in a certain way, has been trained in a certain way, delivers global health programs in a certain way. And as you see from our data from Global Health 50/50 this year, those people thinking and acting in a certain way in global health are generally men. So 70% of the global health workforce is female, 70% of the global health workforce leadership is male. And those figures, again, haven't changed in the years we've been looking at the data. If you look at senior management, who's coming up behind? I'm not sure that I mean, you know, there are some organizations, with gender parity, but we're nowhere near being able to achieve gender parity in leadership. We have estimated that it's going to take us, I think, about 45 years before we start to see notions of gender parity in senior management and leadership really be achieved. So, you know, what we've got is a male-led global health system that is frequently gender blind in its analysis of health problems, and very frequently gender blind in its delivery of data on which decisions in health can be made. So I think that really brings me back to, you know, what is it that I want to get across as a point, or a series of points. And, you know, clearly there's some points in what I've just shown you in those slides about the relationship between sex, gender, and this one health outcome, which is COVID. And we can explore that in lots of detail, because there's lots of work that we've been doing to try to unpack that relationship. But we can only tell you about that relationship because we have the data, and we've really pushed to get the data. And I think that really comes back down to, you know, what is it we set Global Health 50/50 up to do in the first place? It's data for decision making. It's data as evidence for policy decisions, but it's also, and I think this is probably for me one of the most important points for all of you, is this is about data as an accountability mechanism. This is about data that enables us to hold the global health system to account for all of the commitments it has made, not just about gender equality in its workforce, universality, about principles of who should be able to realize their right to health. And if you've got a system that has this very, very narrow vision of gender, which is it's all about women of reproductive age, then you're not achieving universality. And then, you know, essentially the system comes back to bite you when when you're in a situation of something like COVID, which is a respiratory virus that is having its most profound impact on the people who up till now have tended to be left out of global health systems, policies and programs. And that's people with chronic diseases and particularly men. And so for us, it's kind of no surprise that we're now seeing that that's the group that's being most badly affected by COVID, because we as a global health system have given them the least attention over the past, well, I mean, it's debatable, but certainly over the past 30 years. So I think, you know, my main point, I think, amongst the many points, is that really this is about seeing data as a means to enact accountability and change. This is not just data to decide whether an intervention is working, but who's it working for. Thank you.